All right, good evening. My name is Kyle Magatelli. I am the webinar and social media coordinator for Student Doctor Network. And tonight we are doing the Pain Management Physician Ask Me Anything with Dr. Stephen Lobel. So Dr. Lobel, thank you for being here with us.
Happy to help.
So before we kick off, I want to run down a little bit about Student Doctor Network. So Student Doctor Network, or SDN, we are a nonprofit committed to providing resources for pre-health and professional health school students. Please visit us at studentdoctor.net. It's extremely easy to navigate your way around. I can do it, you can do it. Check out the resources we have on there with our primer guide. Community, we are best known for our forum. We have forums for everything you're seeing on that list there. It's a great place to go get involved, meet fellow students, fellow professionals. Confidential expert advice forum, I want to put in a plug for this. I use it myself. If you need an answer, if you have a question and you want a direct answer to get you the information you need, check this out. Extremely helpful. And the pre-med planner app. If you're a pre-med, you're trying to figure out what you need to do to get to where you want to go, check this application out. Helps track everything you need to do from point A to drop in your applications. And finally, if you want to find us on social media, we've got all the usual suspects. You can find out what we're doing, helpful resources, anything and everything. Just check those out. We're Student Doctor on Twitter, Student Doctor Network. Well, I shouldn't be saying this. You guys can read it. So enough out of me. Dr. Lobel, could you please tell us a little bit about yourself?
Sure. Steve Lobel, 51 years old, graduated med school in 2000, training in physical medicine rehabilitation with a fellowship in pain medicine. Been in private practice since 2007 in Canton, Georgia. And I'm just here to answer questions tonight.
Great. All you guys watching, if you have questions, please throw them in the chat box. So the first one, when did you first decide to become a physician and why?
That's a long time ago. I think probably age 10 to 13. Was a good little athlete, not great. Knew I wasn't a pro level at anything. As a kid, everyone thinks, oh, I want to play in the NFL or whatever. I wanted to do well enough to get into a better college than I would have gotten into. And I think with all the injuries I had when you're 13 years old, you're thinking, man, I want to be an orthopedic surgeon, be able to fix this when I see it when I'm older. And so I think, preteen to teen years, I knew I was going to be a doctor of some type. Probably because my mom was a nurse, my dad was a salesman, and knew that I just wanted a good, stable job and wanted to help people. And that's, when you're a little kid, that's all you can think about.
Great. So next question, why did you decide to pursue your specialty?
So when I got started, even at that young age, you always think orthopedic surgery from being an athlete, just because they're the docs you had the most interaction with. I played college football and I had a hip injury. It was a partial open book fracture type thing of the symphysis pubis. So it was basically like a pelvic hip injury. And I was working with one of the residents, and the guy was a total jerk and really turned me off of orthopedics, almost all of medical training. And so looked at, well, what can I do that's similar? And this is even an undergrad where I'm like, man, I think I want to do ortho, but I could do any number of things. I like the problem solving and internal medicine. Didn't know anything about physical medicine rehabilitation, and people still don't know what that field is of physiatry. Occasionally it gets mentioned somewhere, but most of the time, no one's ever heard of it, but it was the gateway into pain medicine. And that specialty, I saw my dad in a bad car wreck, broken hip, and had pain from that. We were in a boating accident together when I was a young guy, probably age 14 or 15, and he had an L1 burst fracture. It was before the days of kyphoplasty, and he was able to get a radio frequency ablation done. And his pain went away and never came back after that. It was about 6 months after his fracture. Additionally, I had a dry socket when I was in college after a wisdom tooth extraction. And that level of pain really completely untreated because I couldn't take a pain pill because nausea, I couldn't keep anything down. It was all lidocaine, and that was it. And about a week of no sleep and being miserable, thinking, man, there's got to be a better way. And that was really the push that made me want to be a pain doctor.
Okay. Yeah, I've used lidocaine myself. Not a recommended experience if you can avoid it, to everybody out there. So, what's a typical day look like for you? What does a pain management physician do?
So practices vary widely in what the day to day is. Mine, I love the mix up. So I'm Monday through Friday in the office, no weekends, no significant call, and it's outpatient musculoskeletal medicine for the most part. I have a mix of new patient follow up and procedures with a procedure suite in the office. So we'll do joint injections, spine injections, radiofrequency ablations, spinal cord stimulator trials, kyphoplasties in the office, and then some in the OR or surgery center. And so Friday afternoons is my reserved surgery block time. And so if there's anything I'm not comfortable doing in the office or insurance drives to the hospital or surgery center, I'll do it over there. So it's Monday to Friday, 7:30 to 3:30. My typical day is 30 patients total, which is a mix of all of the things that I do. And that's pretty much it.
Okay, interesting. So here's a related question. Is it possible to cater your practice towards mostly procedures and mostly med check visits? Do all pain management physicians tend to have similar appointment breakdowns in this regard?
This sounds like one of those loaded questions from one of the forum members. So we got an active community, and there's an opiate epidemic that was, I would say, forced upon us by the government when they thought prescription drugs were driving substance abuse and overdose. There's still that political push. And so people wanted to not take care of pain patients by using opiates. The literature is limited, not favoring the use of opiates for chronic non-malignant pain. And in this environment, there's folks who want out of it altogether. So they just won't write prescriptions for anybody for any reason at any time. And they essentially are interventional radiologists who are not interventional radiologists, or they'll just do musculoskeletal injections, and it could be 20 or 30 or 40 procedures a day, but not longitudinal care of the patient. And then there's folks who are pill mill type doctors where they do nothing but write medicines. And that doesn't really benefit anybody because they're probably doing a lot of prescribing to patients who wouldn't otherwise be good candidates, because most of the folks that do nothing but write prescriptions, it's a hammer and nail approach. You'll get a lot of folks that you shouldn't be treating, but you've got to, earn a living. So there's a mix between what's best for the patient in front of me and what's going to be financially rewarding and what's a community need. And so it's an interesting question because it varies depending on your location, your training, and the patients you see. I do a lot of everything because I see a lot of old people, and old people are less at risk for opiate problems. And they have a lot of arthritis, so I wind up doing a lot of procedures to turn off arthritis pain.
Okay, excellent. Remember, if you guys have questions, throw them in the chat box, please. So here's another potentially loaded one. Can you share a bit about your patient population? I know generalizing is difficult, but mentors have discouraged me from pursuing pain management by citing concerns with the patient population.
And there's something that really opens it up for discussion. I don't want so we can just go ahead and say, well, my patient population is this, and it's almost the same as the last question. When you get into it, it's who are you treating? And yeah, if you're treating the wrong patients, then nothing works. If you have people who just want drugs and they don't want to get better, or there's nothing wrong to start with, well, those aren't really patients. And you've got to differentiate who can be treated, what's the appropriate treatment, and where's the referral base. So you have to know, when someone comes to see me, first question is, why are you here? How did you get here? What do you want me to do? And there's people who are like, I just came in because my doctor won't give me medicine anymore. Well, that's not going to work because that's not a reason to see another doctor. Your doctor is going to give you medicine. I'm not an addictionologist. I don't know your social situation. There's a lot that goes into it. Let me start at the beginning of this question again, because if I'm just going to go down, random thoughts as I get going, I think Kyle, you and I should probably, talk about this, and maybe you could help tease things out. But my patient population, I live in a relatively jaded, affluent suburb of Atlanta, and the practice is in similar location. My average patient age is about 75. And so they have already passed the test of time regarding substance abuse and medication management. Most of my patients are referred by the primary care doctor or local surgeons, mostly spine, some joint. And they're older folks who just want to go out and play golf, play tennis, play pickleball, stay active. It's a pleasure to treat this patient population. If you're in a city and you've got some sports and you've got some low income, all Medicaid, difficult social situation patients, then the practice is just going to be potentially miserable. And when someone talks about a mentor saying, oh, this is a difficult patient population, well, it can be, especially if you're going to write for medicines. You got to know who's getting them and what they're doing with them.
Okay. All right, thank you. So a little less loaded. What's the most satisfying part of your job?
It's making a difference. So, I would say loaded question. I say, oh, when I do a kyphoplasty and a patient pops up off the table and their pain is completely gone. It was something I did in 10 minutes and, grandma or grandpa, the fracture is better. They're going to go out and walk the dog, like get up and go. That's nice. There's the easy win. But it's anybody who returns to work, returns to prior activities with whatever we do. That's typically it. Sometimes there's difficult procedures, technically demanding difficult procedures, and just getting it done. I had a spinal cord stimulator case last week, and it took probably 2 hours. Wires had to get inserted at the base of the spine and run all the way up into the neck, and there was scar tissue everywhere. And technicality, driving. It's almost like video game skills of working a wire to get up the spine, dodging things you can't see, and ligament and artery and nerve and vein and connective tissue to get a wire to go 2 feet up a guy's spine to get to the right spot to get him relief. Just using every little trick you have to manipulate the lead. Bumping it along, twisting it, bending it, getting it so you can safely get it to a location. That reward after an hour and a half of struggle to get the wire to that location, that's satisfying. It's draining and exhausting from a mental standpoint because of the risks involved. And then, the accomplishment of, oh, good, I've got the skills to make that happen. And, when I was a younger doctor, after 10 to 15 minutes, I was making progress, but I'm like, this isn't going to work, abort, and not be able to do it. Now can do it. So I get to learn over time, improve skill set, and that feels really good.
Okay, awesome.
Most of it's just seeing people get back to doing what they want to do. Hey, you did this shot, now I can golf. Or, wow, you fixed my neuropathy. There's this medicine, and how come no one else thought of this? And I said, well, it's easy. If you failed 6 medicines and I'm on number 7 and that's the one that works, it's trial and error. I'm glad someone else did all the trial and error, and now all I got to do is write down one medicine and boom, I won. And there was nothing else. And so, I'll take the easy win when I can get it.
I think that's good advice for everyone. Take the easy wins when they come up. All right, so a question from the audience from Blake Savage. What role do general surgeons have in the pain management process? How do they do generally as clinicians? Is there a loss of follow-up?
So, caveat being, I'm not a general surgeon. I work with some great general surgeons for my hospital system. I'll say I'm a hospital employee. So I've had one of the general surgeons of the group who was in my office for years, moved out in the last 2 or 3 years to join the surgical group. I guess it's not the same thing that you think of like on TV shows where they like to yell and throw things and do that. They're very supportive. They're clinically, excellent in the office, and then they do some really cool surgical stuff. In the pain management process, amazing because every doctor thinks well, this is easy. You just throw medicines at somebody, and then when it doesn't work, you turf them over to the pain guy. And most of the time, that it's just not their training. And fortunate in my situation where I can get the text message from the surgeon saying, "Hey, this is what we're doing. This is the medicines that are already on. What do you think?" There's basic what everyone gets in medical school knowledge about all the medicines. There's the nuance of clinical practice, which is your education, experience, and training. And when you have that different education, experience, and training from the general surgeon, you've got a different outlook, a different take on what's going to be best for that patient. But the general surgeons have been very receptive in getting the help where that's not their skill set. I send 10 patients every 1 to 2 months to the surgeon for different hernias. I don't have that skill set. It's not fixing the hernia. I don't know if a hernia is there. My job is not to put my finger into an inguinal canal or a femoral ring. I can't even tell under large patients if they have ventral hernias. It's not my job to. So if I suspect their patient says it hurts here, right in the midline, look, it's sticking out. That could be a beer gut for all I know. But they want it looked at. I'll get them to the general surgeon. If he can figure it out, great. A lot of times they get CAT scans. And at 1 in 10 that actually have a hernia that needs surgery, we've done the right thing. The other 9 in 10, I do this. It's not my job, but I've got to get you to the right guy and or girl. And so, it's great to have those surgeons there for that. So from a clinician standpoint, everyone's got their job, and I think they do great. There's a little tail end. Is there loss of follow-up? I have no idea. I mean, when my patients go see the surgeon, I see them back because whatever I'm treating them from a general surgery standpoint, or from a pain standpoint as it relates to general surgery, if it's fixed, it's fixed. But most of the time it's their spine, and the general surgeons are, for me, it's lipomas and hernias mostly, but everyone has a gallbladder and appendix that's got to come out at some point, or it doesn't. But I'll see them back saying, "Oh, I like that guy. He fixed this," and it's case closed. It's fixed. It's gone. It's done. So I think that's really nice for the general surgeons, where they want that loss of follow-up. You came in, you had a problem, it was fixed. Saw them in follow-up, global period's over, no other problems, bye. And it's not a longitudinal, I've got a patient I operated on last week, and it was a spinal cord stimulator, and I've been treating him for 8 to 10 years before I even offered that mode of care for his nerve pain. And that rewarding long-term relationship, how's he doing at work, how's he doing when he's not at work, watching him grow older, things get worse, and being able to do something to keep him going. That's what I like best about being a physical medicine rehabilitation pain specialist.
Okay, excellent. Thank you, Blake. So next one, how should pain physicians get trained in minimally invasive spine surgery procedures and other cutting-edge, game-changing procedures?
Whew, that is a loaded question, probably written by one of our active forum members. When I hear cutting edge, game changing, I think that's not for me and that's not for my patients. We'll let the research hash that out. Maybe when we get good 5-year data, we'll step into that pool and see if it's worth doing. And that's a lot of procedures right now that are minimally invasive spine procedures. And I will say that with the right training and understanding the risks and having the right support, including the surgical backup if needed, there can be some really cool, great procedures that are being done and on the horizon that are minimally invasive spine surgeries. Most of those patients would benefit from having slightly more aggressive spine surgeries to fix the underlying problem, rather than a lot of the stuff that we're starting to do, ablating different nerves, adding spinous process spacers, kind of little wedges and clamps and stuff that pain docs will put behind the spine to buy the patient some time. And so we don't have good clinical criteria for these things. It's typically reserved for, well, a patient can't have surgery, therefore we'll try this. Sometimes it's best to leave things be and say, we don't have anything that's proven effective. If you want to try this, then hey, maybe. But I think we're going to get a lot of docs get into a lot of trouble in the next 5 to 10 years doing their cutting edge, game changing procedures and it not working or complications occur. And a lot of it can end overnight because they didn't have a surgeon willing to help them out if they get into trouble. Because you're trying to expand your scope of practice into somebody else's field. And that needs to be something where all fields agree. And when you move too quickly, expanding your scope of practice, doing what other docs do, either identically or similarly, it needs to be shared among the fields and talked about at academy meetings and maybe brought into clinical practice more slowly. And that's not typically how pain works. Pain is, what's the latest widget? I want to do that now. There's a lot of for-profit driven pain management, not for patient benefit pain management, even though no doctor would ever admit that. And I'm on salary, so I don't have a lot of excitement towards that end.
Okay, thank you. Next question, good follow-up here from Tom. Can you talk a bit about the variety of procedures you might have in any given week?
Yeah, sure. There's nothing, well, I don't think anything I do is terribly exciting because I've been doing it for so long. But you could say head to toe or, least aggressive to most aggressive procedures. For hands and feet, I can do carpal tunnel injections, but I don't care to. I don't think they work well enough to be busy doing them all the time when the surgery is a very quick fix. So most of those, they get turfed off to the surgeon. Feet-wise, in the same group as my hand surgeon is a foot and ankle surgeon. So I don't do ankle and foot blocks or joint injections of the ankle and foot. I have the guy who's better at it do it. Working up to the knee, the knees are beneath me, says everybody. Anyone can inject a knee. Family practice with ultrasound, rheumatology, orthopedics, the pain guys. I do fluoro for all my injections. I'm not good with an ultrasound. Do it under ultrasound just as well with the right training. But I mean, anyone can do a knee injection. That's done every day. Hip injections, done with fluoro, probably better than ultrasound, depending on the size of your patient and the body of your machine. Sacroiliac joint, as I work my way up the spine, sacroiliac joint, intra-articular injection, medial branch, lateral branch, dorsal branch, blocks, radio frequency ablations, the entire spine. You can go in and do epidurals anywhere. You can do medial branch block and radio frequency ablation. Shoulder injection, elbow injection, corticosteroids, platelet-rich plasma, tendon injections. I'm trying to think if there's anything exciting. Stuff I don't like doing, but it's in my training. Gesserian block, about 2 centimeters lateral on the cheek. Take a needle in, stick it in under live x-ray into the frame in the valley, wind up an inch behind the eyeball on the Gesserian ganglion and do a block or a radio frequency ablation of that. And that's just, it's just weird sticking a needle up into the edge of somebody's brain. But no one else wants to do it. So it winds up being in my office. And it's usually the trigeminal neuralgia for multiple sclerosis for a post-herpetic neuralgia patient, elderly with Roman numeral 5 sub 1, B1 disease. And that's pretty much what we do. Kyphoplasty for fractures. I'm a own the bone kind of guy. If you're going to treat the fracture, treat the osteoporosis. So a lot of patients on the fancy medicines like Tymlos, Prolia, Forteo, starting to use some Avinity. Because if you're going to do these things, right, treat the patient, not just the bone. Spinal cord stimulators, trials and implants. Trying to think of the other stuff. Peripheral joint radio frequency ablation, hip and knees after surgeries, even joint replacement surgery, they still got pain. We'll cauterize those nerves for them. That's pretty much the procedures we'll do in any given week. There's always some weird stuff with lumbar sympathetic blocks that crop up once a month. So yeah, that's as far as I recall, pretty much it. It's just stick a needle anywhere in the body and make pain go away. You burn something, you put medicine on it. It's a nerve, a muscle, a joint, or the spine.
Okay, that's a pretty exhaustive list there. Tom, thank you for the question. Next one, potentially loaded again. What do you dislike the most about your job?
Some patients will, fall apart and disappoint. So you can be treating somebody for a long time. They get new stressors. Opiate use disorder can become addiction, or patients who uh, just patients disappoint. And there are many, many good patients, but I've had patients who would see me and then maybe I wasn't aggressive enough, or maybe they didn't know that I could do things, but they'll go somewhere else, have a procedure done, and come back and tell me that it worked great or it didn't work. And I go, well, why didn't you tell me? And they're like, oh, I don't know. And so, well, what are you doing here? Well, I'd like to get a medication refilled. And I was like, there's your new doctor. Go find them. Sometimes like a kyphoplasty, patient falls down, breaks their back, and if someone has a new fracture in my practice that isn't my patient but is under the care of the primary care docs in my practice, they'll be seen within 24 hours. And if it's something that we fix, we can fix. So sometimes they're my patient in the community. They fall down, they break their back, they go to the ER, they get an appointment. Interventional radiology does a kyphoplasty. The patient shows up at my office. Pain's not better, and I already had my fracture fixed. What are you going to do about it? And I'm like, all right, well, they put you on osteoporosis medicine. Let's look. What if there was a fracture that was missed? I can't stand when care is not complete. If someone's not doing their job and I'm there picking up the pieces, and I feel like, hey, why don't you call me first? This is what I do. And like that just frustrates the heck out of me. And I'd say it happens once or twice a year. There's patients I'll send interventional radiology for kyphoplasty, for sacroplasty, if it's something I can't do or I can't work out into my schedule. There's great guys that can do it. But if the patient's like, oh yeah, I didn't know you did that, that's not a good excuse if I'm treating them. So it's just like, what are you doing? And then it's okay to say goodbye to those people.
Okay. All right. Next question is from Jared. Could you speak to the current job market in pain medicine and how it may look in the future?
People are getting older. People are hurting more. The pandemic added stress. Stress increases pain. So I have a rosy outlook on the job market and the future of pain medicine. And I am a protected, someone would say, servant to the hospital because I'm a hospital employee. I love being a hospital employee. I don't have to think. It is now 7:27 Eastern Standard Time. I got home a little late because I had to go to the canine ranch and pick up my dogs because I just got back from vacation. I've got a friend and he owns his own practice and he'll be at work for another hour because after his 8 hours of seeing patients, he does 4 hours every day of the billing and making sure the charting is done and handling the HR. He has a potential upside of making more money, but he's also doing twice the work. And then he's got to be the babysitter for everybody in the office. So from a job market standpoint, there's always going to be jobs. They might not be in the best location, and your salary will vary depending on where you want to live and work, depending on how competitive the market is. But there's no shortage of patients. There's no shortage of cool things we get to do. And I still think it's an expanding field.
Okay, excellent. So follow on here. I've heard that reimbursement and pain management have tumbled in recent years. How much, if at all, has had this affect you? And do you expect the trend to continue if indeed the rumors are true?
I don't know where rumors come from. I mean, you get paid a certain amount. It's determined by your contracts. And so there's Medicare sets a reimbursement rate, and all the insurance companies will peg a percentage of Medicare based on the contracts you have with them. So fortunately, I don't get paid in dollars. I get paid in something called RVU. I get my little pellets of relative value units, which are valuable to cash in for dollars at some point. Kyle, I'm joking. That's how they pay you as a hospital employee, RVU. And I know you're a pre-med or med student. So the reimbursement, whatever it does, I'm under a contract with the hospital to pay me the relative value unit as provided by the AMA and Medicare. And so it is what it is. If the reimbursement goes down and my relative value unit stays the same, then I guess my pay stays the same because my dollars per RVU is my negotiated contract rate with the hospital. That's what I get paid. If the hospital gets paid less because reimbursement goes down, When it's time to renegotiate the contract with a hospital, that's where the issue will be. And if you're in private practice and you are at 110% of Medicare with your Blue Cross Blue Shield or Cigna or whoever, well, if it all drops, it drops, and you have to account for that in your practice. Those are the stresses of private practice. That's supply and demand and regular business. But where I'm at, I don't do business. I just play doctor. So I don't think about those things. The basic premise here is the more procedures getting done, the value will have to go down. When there's creep and scope of practice where nurses in certain places are doing epidurals and radio frequency ablations, the reimbursement goes down, because if you don't have to be a doctor to do it, you don't have to get paid so much to do it. So there's lots of issues that go towards that. There's a lot of overutilization that really it'll limit how many procedures get done in the future, because they're not going to be worth doing. Physical medicine rehab saw that with EMG nerve studies when they were paying very well 15 years ago or 20 years ago. And then everybody started doing them, and physical therapists with electrophysiologic training started doing them, and 99% of the studies were useless, and the reimbursement got cut 100%. People are getting pennies on the dollar of what they were doing. So now, not many people do them. It's done only when absolutely necessary because of the overutilization. And so, once it's gone, it's gone.
Okay. And guys, keep those questions coming in the chat box, please. So next one, do pain docs ever have side gigs? I have heard that some may work as expert witnesses in court hearings. If so, any idea on what this sort of work looks like or how it tends to be compensated?
When someone throws in side gigs in quotes, and it must be one of our forum members, and they must know that I don't have a side gig, but I do have a 1099 LLC. And so I'm Stephen M. Lobel, MD, LLC, and I do offer medical legal consulting. Most of that is through governmental agencies. So I've done consulting for medical board, the DEA, the Department of Justice, and that's very rewarding to me, because if a doctor is misbehaving, we can help find them help for that, or jail for that, or fines, or loss of license. And then when I feel like it, I can do private attorney work for medical malpractice or utilization reviews. So I've worked with large, forensic accounting companies, where if a doctor all of a sudden has a 300% increase in the billings, and he's a hospital employed physician, they'll throw me some charts, and we'll see if he's actually doing the work. And so it's fun playing detective as a doctor for me, and it pays well. And so I can earn income without doing extra work in my office or taking out my frustrations financially from what I get paid from a hospital on my patients by being an overutilizer myself. I get to do what's right for my patients and what's right for my community by policing what is going on from a prescribing standpoint and an overutilization standpoint. And so what does it look like? How does it work? You get letters from attorneys. They'll send CDs, and they'll say, do you have a CV, a fee schedule, and would you be interested in reviewing this case? And it could be medical malpractice, it could be business negligence. There's any number of things that I get asked to look at. And, what's wrong here? It's, did someone break a law? Did someone commit malpractice? There's a lot of different questions to be answered, and it takes a medical doctor to do it. So, why not? I think it's fun.
Okay, excellent. So, little lighter question. How do you balance work and your hobbies?
I have the right job. My hospital system, we had a bumpy month or two, November, December last year, with a contract renegotiation. And there wasn't great admin support initially. Then there was fabulous admin support. And so all the doctors that I work with all re-signed up, and our stresses went away, and the hospital's taking care of us. And so my work is 7:30 to 3:30, Monday to Friday. Later on Fridays when I'm stuck in the OR doing what I love. The rest of the time, I get home, and I'll go typically half hour to an hour of exercise as soon as I get home, and then dinner, and then usually down here in Georgia, we've got enough sunlight in the summer. I'll go in the garage and I'll tinker on a race car, or I like rebuilding Jeeps, and I got a couple of Jeeps I'm working on. So from a hobby standpoint, it's there's plenty of time when you're an employed physician to do your 40 hours, and then instead of being like my side gig or game changer buddies, I don't have to sit there and run a practice and try and make sure every dollar is collected, every employee is happy, and keeping the lights on. And that I'll go out and work on a Jeep.
So, me myself, I like your approach here. What I'm hearing is when and if the day comes, go work for a hospital. I like having free time too.
Well, but so the argument is, if you're going to do that, are you selling your soul? There's something called site of service differential, and the cost of care may go up depending on your hospital and where you do your procedures, where you see the patients. There might be more money involved, and you can be draining money from the system. My hospital and for myself, we don't do it that way. So we're in the right situation where we're not draining the system of all the money to make the most money off of insurance. And so that's working out well for me. Other guys need that autonomy. They have administrators who will tell them, you need to put every order in the EHR, otherwise you can't do a shot. So a doctor could spend 5 minutes charting to do a 1-minute epidural. And or you have to type in your notes. So sit there at a computer. Okay, well, so-and-so is here for this and that. And they'll spend 5 to 10 minutes typing and entering orders rather than seeing the next patient. And the burnout and the frustration, that will go way up because I'm not an order entry clerk. And I'm going to face it, a lot of docs don't have the chutzpah to come out and say, yeah, that's not my job. If someone wants to make money off me, they want my face in front of the patient's face as much as possible. If I sit at a computer, they're losing money off of me. They're hurting the physician enterprise value of the things I do. So if I'm typing and not talking into a dictation, if I'm sitting around doing admin or non-clinical work, you're wasting the top of the license for the ability to generate revenue for those people. And again, I'm on salary, so don't make me be a typist when I could be seeing that next patient and the administrator could get a new Lamborghini every year. And hey, more power to him. Do I care? My Ford race car is faster.
So next one, how might things be different between practicing pain medicine, e.g. solo PP, employed PP, inpatient, VA?
So really talk a little bit about that. The big thing is, well, inpatient, there really isn't inpatient pain medicine. You can't make a career out of that. There's not enough patients. You can have an inpatient service. And I know nothing about that because I never did it, because that sounds terrible to me, where it's, I guess, labor and delivery and post-op pain and placing epidural catheters and just doing perioperative nerve blocks. That almost sounds just like the practice of anesthesia, not the practice of pain medicine. But when you talk about employed and solo private practice sounds lonely. I'm the only pain doctor at a group that's had up to 20 different doctor, nurse practitioners, PAs at a time. I think we're 10 or 15 right now in my building. So I'm the only pain guy, but I get 5 times a day, internist or family practice walks up. Can you pull up this MRI? Let's look at it. When can you see this lady? Here's what the pictures are look like. So I love that because it's like being on grand rounds every day. People run up, hey, can we look at this MRI together? Oh, hey, what can you do about this? And get to chat with the doctors face to face. That's better care for the patient. That's a lot of fun. VA. So the VA is its own beast. Some VAs do fabulous work and others, they don't want to do anything. There's folks working at VAs that can see 10 people in a day and that's it. There's folks that say, oh, we can't do this procedure because this VA doesn't allow it. And it could be a spinal stimulator or kyphoplasty. So why don't they allow it? Well, because the guy who is in charge of the department never trained in it and he doesn't want anyone doing it underneath him. It could be ego, it could be whatever, but it's a governmental agency. So it's really, before you go to a VA, find out what they do. And if they're not currently doing it, is there a process in place where if you want to be there and they can change to fit your practice, great. Otherwise, you just can't go there because these are our veterans. We want to take the best care of them we can. Difficult patient population. But if you go there saying, oh, this guy needs treatment X, and they're saying, no, we don't do that here. That doesn't make sense, especially if it's a standard of care treatment. And that's what I hear about the VA. It's very location dependent, staff dependent, and then it's it's not always run by the doctors in a department. There's always some admin who is a government official of some type at the VA. It's bureaucracy. Things may never get done, and so that can be the tricky part. You have to be very careful when going to work at a VA. Training at a VA is great. You can do whatever you want while you're there, and I had a great time. Basically, I was a PGY2 running a private practice for musculoskeletal medicine. I had my own office and my own patients, and all you had to do is run it by the attending. And then, granted, this was a long time ago, but they would say, yeah, go ahead, do what you want. That sounds great. And so you really get to grow as a physician when you're just thrown out there saying, do what you can for these guys. Any questions, come get us. It was a great place to train.
Cool. All right. Next one. What advice do you have for students interested in pursuing pain medicine in general or pain management medicine?
I mean, if you want to do it, right? It's, if you're like out there listening and watching, if you have an interest in being a doctor, be a doctor. Go study, go take your tests, do great on everything, be competitive, and then just go out there and do it. I mean, I don't understand the question. Advice, interested in pursuing medicine in general? Don't do it. Like, I regret everything. I think there's doctors burnout. I'm sure there's people like, well, I guess there's surveys, right, that say, oh, most physicians don't recommend people going to medicine because of X, Y, Z. And I don't know. I mean, I couldn't do anything else. So I'm not qualified to do anything else at this point. I mean, my welding skills were better. I could probably do some fabrication work, which would be fun. But, this is the career I chose. And if you choose it, do everything you can to get better at it every day. Read the books. I was looking over there. I got a bookshelf. I got this is backwards. There's a old radio frequency generator. There's a clock next to it. You can't even see them in that little rectangle. I've got some needles used in one of the initial studies for radio frequency ablation. Love what you do. If you love what you do, does it really work? Yeah, it still really works. Rewarding work. It's good. It's who I am. I am me, and this is my job, and I have pride in my work. And that's upbringing, right? That's what your parents tell you. Be a good person, work hard. That's it. And this is what you want to do it. There's a lot of doctors like complaining about everything. Yeah, it's fun to complain to each other. It doesn't fix anything. I'd rather work on fixing things.
Okay, awesome. So, Dr. Lobel, we're coming up on about time, and I had one final question, and you just answered. If you had to do it all over again, would you still choose your specialty?
Yeah, there's nothing else that I could do. I love my base training in physical medicine rehabilitation. I think it prepared me better than anesthesiology for the doctor-patient interaction. All the chit-chat, all the talk, the nuance in communication, you get that in physical medicine rehab. You get a lot more musculoskeletal anatomy training. And so it worked out well for me for what I do in practice. Granted, anesthesia has much better skills coming out, much better ability to handle the complications if and when they occur. But for the practice I'm in and what I do day to day, my training was excellent. I would do it exactly like I did it again because it made me who I am now. You can't take that back. You're different based on every decision you make. And so I'm glad the way things worked out, and looking forward to getting to work tomorrow and going to the OR tomorrow afternoon.
Excellent. Well, Dr. Lobel, thank you very much for your time, for answering these questions. Your field's something that I've been interested in, so it's been cool to get to learn more about that. Thank you to everybody for asking questions. And if you tuned in late, the replay will be going up immediately following here. So again, Dr. Lobel, any parting shots or anything?
Oh, that's it. Have a great night.
Excellent. All right. Thank you, everybody. We appreciate you tuning in.